Dr. Dipanshu, it's live. I think we can start.
Yes, sir. Aarti ma'am, can we go ahead? I think, sir, I'll start.
Yes, Dr. Dipanshu, I think because live is being shown, I think it's already streaming on YouTube.
All right. So, good evening to one and all.
Please start, Dipanshu. Please start. It's already live.
Okay, ma'am. Good evening to one and all. So, we are here with our third session, third webinar of this series, medical legal aspects. And today, this medical legal aspects series we had started actually in month of around March or Feb, and under the able guidance of the YOSI Governing Council and executive members. This is the core team of YOSI Legal, and under the able guidance of Dr. Kaushik Tripathi and Aarti Heda ma'am, we have been able to conduct conduct a survey, which we got a very overwhelming response. And following that, because of the overwhelming response we got, we were able to get a position for a session in AIOS 2022 in Mumbai. And the session was a good, successful session, and we had good discussions on medical legal aspects. Following that, we started a webinar series. Every month we are hosting a session. First session was on consent. Then second session was on Consumer Protection Act. Now today, our third session is on medical record, maintenance of record keeping. So today we have our esteemed panelists, Dr. Anand Deshpande sir and Prakash Marathe sir, and we have two very great speakers, Professor Dr. P. Nirmal Frederick sir and Dr. Anil Gangwe sir. Dr. Anand Deshpande sir, he is Director and Eye Surgeon of Dr. Guru Prasad Netra Rangnalaya, Aurangabad, and he is also Director of Indian Medical Legal Consulting Services Private Limited and Chairman of various legal committees. Sir has a long list of awards with him. I welcome you, sir. Next up, we have Dr. Prakash Marathe sir, who is the consultant ophthalmologist at Netra Yogi Eye Clinic, Pune. And sir is also Vice President of IMA Maharashtra State and Trustee and past President of Pune Ophthalmic Society and IMA Pune. Sir has also designed consent form in Marathi language. We welcome you, sir, for these sessions. Both our panelists have been constantly guiding us from our session 1, and we thank you for that, sir. So I'll be introducing our first speaker, Dr. Anil Gangwe, sir. Sir is consultant vitro-retina and ROP services at MGM Eye Institute, Raipur. He has graduated from Mumbai and post-graduation is from RP Center in New Delhi. Areas of special interest of Dr. Gangwe is retinopathy of prematurity and its medical legal implications, neonatal care and progression of ROP. Sir has introduced tele-ROP screening, developed ROP screening date calculator, introduced lens-sparing vitrectomy for stage 4 ROP in Chhattisgarh for the first time. And he has been the organizing secretary of ROP Society annual meet as well. And he has various publications to his credits under ROP. He has also recently won IGO Silver Award for his work in ROP. So we welcome you, sir. Sir, over to you for your talk, sir. You can please start sharing your screen, sir.
Yeah. So thank you, Dipanshu, and thank you, Kaushik and YOSI Cell for this opportunity. I think I have been facing many of these problems, and even though my areas of interest are usually medical legal implications related to ROP, I think this gave me an opportunity to read about the other or adult side of this perspective. And Dipanshu, I think it's visible. Shall I go now?
Yes, sir. Please go ahead.
So I think we'll begin with this, and most of the slides and the screenshots that I have used in this presentation are from our EMR, which we are using in collaboration with L. Prasad Eye Institute, Hyderabad. So I think
sorry, just can you make it
go to the slideshow?
Full screen will be visible.
Slideshow.
So it's a slideshow, sir. It's
no. It is small, cannot be ready.
Small slides are seen. Just
yeah. You go there. Here. That's correct. There you click.
So, is it fine, sir?
No.
Not yet, sir.
You go to the no.
You can start sharing again, probably.
Yeah, again start sharing.
Dipanshu? Is it there
Yes, sir,
now?
now it is
Yes, yes, perfect, perfect, perfect.
Okay, so let's begin. So if we, oh, now it's not moving on. So
Yeah.
It is,
yeah. Being a retina surgeon, if you just come across something like this in your OPD, someone like a splashed potato, splashed tomato, and we are diagnosing him as ischemic CRVO, and somehow if you fail to explain him the need for regular follow-up and the probability that he will need follow-up so that we cannot we can detect NVG or neovascularization or else complication earlier. So if he gets lost to the follow-up and lands up with NVG, and probably if we have not explained him the need for regular follow-up and have not documented it, or if we have failed to do something like gonioscopy on regular visits, then we are in a soup. And if something like a medical litigation or something like a medical legal case goes against us, that in that condition, who will be believed in the court of law? It is obvious that the patients, again, they have a sympathy corner and they will be legally correct. And if you have not recorded things very well in our record, of course, we won't be able to defend ourselves in the court of law. There comes the importance of our medical record. So why do we really need to keep this record? Is of course for identification and clinical research that we need to identify certain trends or in relation to your particular patient or over the period of time. But the last and most important thing is it's to protect ourselves, because we are in the era of medical legal litigation, and we never know that we may need to justify our action in the future, why we have done certain things for the management of certain patients. And as per the law, I think sir will know, and that if you have not written or nothing is mentioned on our record, it doesn't mean that we have not done, but court will say that if you have not written, have not done it. So how long we need to keep these medical records? As accepted, it is for OPD patient, usually 3 years. For IPD or indoor patients, surgical patient, we need to keep it for at least 10 years. Initial period can be, hard copies can be kept for at least 3 years, and they can be digitalized and uploaded to EMR later on. For pediatric cases, at least we need to keep this record as long as the children, they are not reaching 21 years or they become so-called adults and they are able to take their decisions. And for medical legal case, at least 30 years, or as long as the judgment or hearing is on or has been passed, then we need to maintain such medical legal records. And for casualty cases or the casualty register, they need to be again maintained for 30 years. So how basically the next part of presentation will be how we are doing it at MGMI Institute. So whenever patients are coming to our OPD, we are taking a general informed consent that the patient is willing for his eyes or examination to be conducted at our institute. So we are starting with a consent for examination. Then it's a EMR kind of a system, and we have identification of the patient. So photographic identification is also important, and we are able to monitor in the EMR system. And important thing is in ophthalmology, though history is not very much exhaustive, but we should maintain that certain conditions or certain elements related to the patient's past history, his surgical elements, and with due attention to his current medical history, systemic history, shall be documented. In ophthalmology, what is different from other specialty is the binocular status of the condition. So certain people who have already lost their eyes, we have a system to mention that these are one-eyed kind of patient or none-eyed patient, where a special attention is given to their management. Again, mention about their systemic histories like Down syndrome, diabetes, duration, everything has to be mentioned. And of course, here we tend to describe it in red so that it's highlighted and we do not miss on these things. For example, like mentioning the arteriovenous fistula, then need for avoiding NSAIDs in patients with chronic renal failure. Coming to the examination part, the facial asymmetry, all these details are usually for pediatric or oculoplasty patients. However, The detailed anterior segment examination is described here. And important thing is that we should also mention certain important normal findings. For example, these are patients with ocular trauma, closed lobe injuries, patients with CRVO coming for follow-up. We are commonly doing their gonioscopy, or anyone presenting with high intraocular pressure, we tend to document their gonioscopy at first visit as well as at regular. The post-dilated examination is very, again, exhaustive. If you just look at the lens status, it's very thoroughly described. If there is any phacodonesis or pseudoexfoliation, it is very thoroughly described. And if you really follow this, again, the documentation will be very thorough. So ideal circumstances, it has to be done. And for most of our patients, of course, we need to follow this. The fundus examination is again a very important part, because most of the patients, or many patients in ophthalmology, they tend to get something, they just undergo cataract surgery, and if they are not getting a postoperative good visual outcome, then it will come to documentation like, have you seen the fundus? If the fundus was not visible, have you documented it with a B scan? And in such cases, such kind of documentation will be either prove in favor of you or it will prove against you. So mentioning important normal finding as well as some of the important negative findings, for example, in presence of lattice degeneration or presence of retinal hole, presence or absence of PVD, these are important negative findings that we need to mention. Again, whenever we have access to this fundus photographic documentation, we must do it, and it should be done in a serial manner so that we will be able to justify ourselves and even explain to the patients. So that is very important. Whenever possible, we should do it. And again, in this EMR system, we try to scan each and every consent, each and everything like discharge summary, the encircling element, their model, then the expiry date, all possible explant like the silicone band, implants like silicone oil and intraocular lens. We are keeping their stickers and getting scanned them so that in cases of any future intraocular or extraocular infection, we can actually get access to this. So this is a good thing. And next thing was that we should be very much clear about the plan of management, and we should be clearly explaining it to the patients. For example, in this case, why we are advising hemogram and why we are suggesting for blood transfusion. So whatever we are explaining it to the patient has to be very thoroughly documented in our plan of management. Of course, this is a case of ROP which has came late night to me, and parents were, of course, this was the case of AP ROP, and the parents were very much conscious. They were worried about the baby, of course. So we need to spend time with the parents. We need to spend time with the patient. We must give a sufficient time to explain them each and everything. But what I find more important is we must take extra time to document all these things. If we have taken effort to explain, we must take another extra effort to document all these things. For example, we must justify our action. Suppose this is a case who had optic atrophy but had proliferative diabetic retinopathy or complications of CRVO. So aim of that PRP was to just prevent the risk of progression to NVG and not to improve or prevent the severe vision loss that we usually explain to the patient. So justification for our action has to be there, mentioned in our plan of actions. Then, of course, I think you people have gone through the consent. We are taking consent for almost each and everything, which are, of course, required. We are taking financial consent. We are taking consent for any blood collection, HIV form. Again, next thing in ophthalmology is identification of the patient and verification of the eye. So getting a wrong eye treated is a difficult scenario to handle in the court of law. We have different bands for different type of surgeries, and we mention the patient's detail on these bands so that we are not missing on the eye or missing on the patient. However, under general anesthesia, we may not be able to verify the patient's eye verbally by talking with the patient. So such special and extra time must be given whenever we are doing something under general anesthesia. And even in vitreoretina, we have many patients who are undergoing bilateral kind of procedure, intravitreal injection in one eye followed by other eye. So care must be taken that we don't inject something wrong in the wrong eye. So this is how we are doing the identification of eyes in MGM. And these are the surgical checklist that we are following. We are having different level of check at different level just to make sure that we are operating on the right patient with the right eye. Yeah, I think I will just be quick enough. Again, I have just kept this because this was one of the patient of mine who suffered cardiac arrest during silicone oil removal. So we need to be very truthful to ourselves and did not try to hide the things, because the situation was so rapid that I have to just close the sclerotomy and keep the peritomy open, and the eye was closed. The patient was referred to the anesthetist so that we can. So again, justifying, this was a patient of CKD whom we have accidentally injected injection overon, and this, though it was mentioned that he is a case of CKD, we could have very easily wiped out this, we could have cleared this, but again, it's not only about hiding the things. We should not try to cover up things and cover up the complication. However, corrective action, like for example, if he was given overon in presence of CKD, the next thing that could have been done was we just referred the patient to a nephrologist and just explain it to the patients that yes, something has gone wrong, we were wrong, but nothing is going to happen you acutely. And we got his creatinine and everything was fine. But we did not try to cover up the things, and we did take the corrective action. And of course, on the subsequent follow-up, we have taken some preventive action so that things are not repeated in the future. So if you look at the medical record documentation, there is no end to it. The ideal way of doing it will be very exhaustive. However, it will be very safe. But to be very ideal, it will be a time-consuming thing. We can lose on our patients and time. And in India, I don't know how realistic this approach could be. However, the record keeping somewhat should be optimum so that we are not facing or exposing ourselves to a medical legal litigation. So aim should be that we are not maintaining any inadequate medical record which will prove against us. And unfortunately, if something goes to court of law, we will get a judgment, and it is not necessary that every judgment that is passed will serve a justice. So there is a distinction between judgment and justice. So I think we should try and cover ourselves with very good documentation with a medical record. And lastly, we should have very good professional indemnity insurance, because every day we are hearing about these cases and we may not be able to, because even with the best kind of effort, things can go wrong, and we must be ready with the tertiary level of prevention for such kind of things. Thank you. Thank you, sir.
Thank you, Anil sir. Sir, it was a very crisp talk, I would say. You have covered, I think, everything for a new ophthalmologist who would want to know how to document in his or her practice. So shall we go on to the next speaker, Kaushik sir?
We'll take the questions later.
Yes, sir. One second. One second. Sorry for the technical glitch. Next upon, we have another great speaker, Professor Dr. T. Nirmal Frederick. Sir is Managing Director and Consultant surgeon at Nirmal Eye Hospital, Tamram, Chennai. Sir has done his graduation and postgraduate from Madras Medical College. And following that, sir has done various degrees in hospital management and NGO management. Sir is the lead auditor in ISO 9012-2008, and sir has been an NABH assessor as well. Sir has a long list of awards, and he has been empaneled principal assessor in NABH, chairman for insurance committees, co-chairman for multiple committees, and he has a long list of awards. He has presented over 100 scientific papers and instruction courses. And without further ado, I would request Nirmal sir to please share his screen and give his talk.
Nice.
Yes, sir, it is seen.
Okay, thank you. So let me at the outset congratulate the Young Ophthalmic Society of India, the entire team, for this wonderful opportunity and all the wonderful work you've been doing. My only regret is this was not there when during our formative years, and I think now we have passed the age of becoming members, unless you relax a bit on the age limit. Right. So thank you for the kind invitation, and it's indeed an honor to join my good friend Dr. Anand Deshpande, Dr. Prakash Bharate, and the moderators Kaushik Tripathi, Dr. Deepanshu, and also wonderful co-speaker Dr. Anil Gangwe, who has made my talk easier, because all the basic aspects and the important aspect he has covered. So my job is easier. I'll just reiterate some of the key points. And also thank you YOSI Legal Core team, especially Dr. Aarti, for bringing me here, and all the wonderful office bearers of Young Ophthalmic Society. So my talk today is on the basic and standard requirements for accreditation and medical legal aspects. I'm sure you've already covered the medical legal aspect in the previous two sessions. But anyway, I'll start with some of the basic things so that you understand it and start implementing in your day-to-day practice. Right, so this is the definition of a medical record or case sheet. It should be clear, concise, and accurate history of patient life and illness. It's written from the medical point of view, basically a complete compilation of scientific data. It has to be in an orderly way, documented and preserved by the medical records department and filed away for various uses. So this statement comes from Dr. Markham, who is the father of medical record science. And this is a simplified way, clinical, scientific, administrative, and legal document. So it conveys everything relating to patient care, in which is recorded sufficient data written in sequence of event to justify the diagnosis and warrant the treatment and results. If you see the medical legal aspect, this completely reflects what exactly the legal department requires from us. And this is also used in identifying the standard of care, because used in measuring the medical care rendered by the hospital and its staff. So good medical care means good medical records. So basically, if you have a good medical record, you are reflecting your standard of care and good medical care. So this actually simplifies the both definitions. So what is the purpose of medical record? So it is basically a patient chart or patient file where we convey all the information and all aspects of patient health care as well as quality of care given by the care providers. So it's important for our practice as well, not only for the patients, but also for our patients, us also, because it reflects the continuum of patient care. So not only OPD care, but also when we suggest some investigation or procedures, it reflects in the continuum of patient care and then up to the discharge. Then, of course, we all know the importance of financial and legal success of practice. So medical record is directly proportional to this, and of course for research and audit purpose. So what is the current status? So this is what some of our medical records look like. So these are actual medical records, and so this is actually an abomination. It's a disgrace to the profession that created it. And more often we see that, particularly during your assessment, we see that the chart is thick, tattered, disorganized, and illegible, and commingled in accession sequence. So instead of enlightening us, it actually confuses and provides a challenge to anyone who try to understand what is happening to the patients. So this is the current status. So where we need to concentrate and improve. So these are some of real challenges in medical and ophthalmic practice. So one is the information storage and retrieval. This is for the organization. Larger organization have a larger problem, larger challenge. And it's also now a logistical problem for us, because paper records, there is wear and tear. We need to have proper backup and can only be at one place at a time, particularly when there are a lot of branches and corporatization of medical care where we need to see the records in many places. So this is indeed a challenge. And of course, now research and audit is another requirement for any practice. So there is not only complexity, but also many challenges. So this is a record of one patient, a VIP patient in our state, one patient, 10-day stay, went through 6 departments, and 105 healthcare professionals saw her, 370 pages plus 257 reports and images. So how do you manage this huge record? Particularly now we are generating in ophthalmology a lot of images, a lot of investigation and reports. And particularly if you are taking FFA, there are about at least 60 images, and OCT have so many images. And if you are following the patients, it adds to the complexity and challenge. So this complexity and challenge is not only for the medical providers, it is for every stakeholders in the healthcare industry. So we are in the center stage, so we feel a lot more stifled and challenged. So for the patient, again, it is a challenge because he doesn't understand the medical parlance. For the government, it is a challenge because they need a lot of information and data about public healthcare activities. And for the health insurance, they want in a particular format. For us, it is a challenge. And for the social media, they don't understand social media or any media, they really don't understand. What they know about medical care is the word called botched, and they keep repeating that. And so there's not only that, there is information need and overload. So how do we go about, how do we change our system, or how do we understand the system? So we need to understand certain basic requirements and standard requirements so that we don't add to the complexity and challenges. So I'll be describing you something about the importance and also the format in which we need to record medical information. So this we are familiar with, called as SOAP format. I'll try to tell more about this. And then there are understand the various parts of the medical records, what we called as POMR format, problem oriented medical record. And of course, what is the standards and medical legal requirements. So I'll also be going through some keywords, abbreviations, the EMR guidelines, etc. So these are some of the acronyms or key terms we generally be using in medical records. So assessment is the entire clinical examination. So basically for us, it is the ocular assessment, visual, the optometric assessment, and then the assessment by our allied medical sciences and other people involved in the care provision. CC is the chief complaint, diagnosis, family history. We are all familiar with this methodology right from our medical college days. And we also need to have review of systems, particularly when you are going for accreditation or any auditing. And we also need to understand what exactly is called as care plan. Right. So why should we maintain medical records? Because it's a source of information for carrying patient care. It's a record of treatment, record of quality of care, and it's a tool for communication. So this aspect is very, very important from the medical legal point of view. Particularly the CCC is important as CCC in our cataract surgery. Communication, consent, and continuity of care. And legal record for the practice, very, very important. And now for insurance, the record for reimbursement is gaining importance. And of course, data for research purpose. And there has to be an order for our medical records. So this we call it as SOAP method. So the subjective findings, so what the patient tells us, the history of present illness, past illness, social history, all those things, the way we present in our exams and medical college days. The objective findings, what we analyze and assess from the patient point of view, and then also called assessment, and then diagnosis or provisional diagnosis. And then to arrive at the final diagnosis, we do certain management, we do certain procedures, and also prescribe medications, patient instruction, and give advice and recommendations. So this is called the SOAP method. So our medical record should follow this method for easy understanding, because this is a universal method of writing a medical record. And the next comes the POMR method. So most of the clinicians follow this because it is less time consuming. Since you've come from the medical college background and now into the practice, we have a lot of time constraints to we may not be able to go through the detailed record. So you need problem-oriented medical record. So complete patient history and information, and the complete examination and test with the reports. And then the initial plan or provisional diagnosis with the initial plan, and then run through the patient problem, which has been recorded already in the SOAP format, and then arrive at a provisional diagnosis, and then management, including investigations and the treatment part. So this problem-oriented medical record is what followed in many of the countries now, particularly in with reference to the insurance documentation. With reference to the quality assurance, the NABH or any standard organization feels that medical records implicates the quality of care, and that is why documentation plays a major role in any accreditation visit. And particularly the record should contain certain things. I'll go to those standards later on. So what do we find during the audit and assessment during accreditations? Unless you know what exactly we find, then you can't sort it out. So most often it is doctor related. So the most common offender in a medical record is only our doctors. The entries are inadequate, illegible, not signed and not dated. And so we were given some easy way of doing that. Inappropriate abbreviation. We create our own abbreviations, so it is not known to anybody other than us and our team. The timing, date, dose variation, which leads to a lot of medication errors, and non-return of records. Many of us take record from the MRD and we don't bother to return it back. Our team, not only the nursing team, but the optometrists, the MRD related staff, they also contribute to this common problem. Most often it is wrongly filed. So one file of a patient will be with another file, or it may be in the doctor's chamber. And delay in coding and indexing. Now with insurance coming up, in many ways, coding is becoming really important. And no follow-up of non-return document, poor filing system. These are some of the challenges. So how do we address these challenges? So now we need to know about the actual requirement from the standards point of view. So this is recorded in Chapter 10, Information Management System of National Accreditation Board for Hospitals. Right, let me move on. So we need to understand the standards. So these are three important patient safety aspects. So one is you have to capture data at the point of care. The moment you delay this, there is missing information and also a lot of missing entries. And if you communicate the same thing to other person, there can be some addition and deletions. So you have to capture medical record at the point of care or at the point at source. The second important aspect, you have to integrate data from multiple internal and external sources. Particularly when patients come for second opinion or third opinion, they have a lot of papers and images and reports. So you have to really integrate all this data from multiple sources. Even in a big hospital, there are a lot of multiple internal and external sources. So you have to arrange it in a chronological order to get the story of the patient. The third important aspect is to help in clinical support, care decision making, care plan, the communication to other co-workers or your management to reduce errors. So these are three core areas where you have to focus on. And you should also address these WH questions. So who should do this? and what should be done, when it should be done, so where it should be stored, how it should be stored, and why it has to be used this way. So this is the intent of information management standards. So it's an important resource for effective and efficient healthcare delivery. Ensure data and information meet the requirements of standards, and right information is made available to the right person. So these are the summary of standards. So I will not go into the details. I'll just go through the important features. So we also have the EMR and EHR system. Most of the EMR and EHR system now come integrated with the requirements of accreditation. So if you have a EMR or EHR, the understanding and integration becomes easier in a mid-level or bigger hospitals. So standard one is there has to be standard policies and procedure to meet the information needs of eye care providers, management, as well as other agencies that require data. So how do we go about this? So any medical record, if you're creating a medical record, it has to have a unique identifier. Some hospitals call it as UHID, some hospitals call it as MRD number, and the organization should identify who's authorized to make entries. So a nurse cannot make an entry seen by a doctor. A doctor should not make an entry seen by other people. So it has to be the authorized personnel, and all record have to be dated and timed. An author has to be identified, and the contents of medical record have to be identified and documented. So this is the basic standard. Let me go through the documentation part of it. So any entry in the medical record, you have to just, particularly if it's an inpatient, you have to justify admission, justify the hospitalization, support the diagnosis, describe the patient progress, and it should be legible. So EMR solves many of these problems, and of course it adds to the complexity. And this is what NSDT is very, very important. So dated, timed, and signed by the individual providing the care. So information needs, if you have a EMR, it is easy for the doctor, for the care providers, for the management as well as, because at the end of the day, we know the entire data sheet. And then of course, formats have to be standardized. So even if you have manual records, so ensure that all of us use the same data as a data collection form, and it should be available for analyzing the data. So this is how you need to design and control. You need to have well-designed form, ensure all data are collected. So if there is a column that has to be filled. So this is the information and order the management or the senior leader should give to all the staff. And this also helps in reducing the waiting. Very often there's a lot of complexity, a lot of data required that increases the waiting time. So you have to ensure that the form is crisp enough and also collect all the data that is needed. Avoid duplication of info. So in many of our hospitals, I've seen about 150 hospitals for NABH assessment, another 100 for ISO. A lot of duplication of work. It adds to the complexity, and it also make the staff lose interest in creating a medical record. So you have to avoid duplication of info. And then legibility and concise information. So all this can be solved by standardization and centralization of this record making. So ensure that there is no individual forms by doctors, however big the doctor is, or however more revenue the department generates. So how do we implement? So assign a UHID or MRD number. It has to be self-generated. And if it is a manual entry, ensure that MRD and UHID is recorded in all the sheets. And if it is electronic, tag it for all the records. And have to be identifying the contents of the medical records. And documentation part, you need to identify the authorized person. So this has to be done through a proper training, and also the policy should reflect this. And in case of EMR, automatic generation of date and time by the system is preferable, because that really helps over a period of time. So how do we identify the author? So this is the SNDT form, signature, name, date, and time. If you have a seal, that solves most of the problem. And also cross check if you are used to writing the initials. So ensure it is same initial for one person. And electronic signature can be used. So now that it has come, all this can be easily managed. So the second standard is you need to have a complete and accurate medical record for every patient. So these are the standards. So I'll just highlight some of them. The content of the medical record, right from admission, initial assessment, progress notes, the glass and medicine prescription. Very often we see the glass prescription is missing. So you have to ensure that the optical prescription is there. Then reassessment. So if they are coming for a review, and procedure assessment. Most of us run daycare centers. If you are coming for a procedure, that has to be part of this medical record. The consent forms, the discharge summary. So this is the complete medical record. And if there are other records like chart notes, when you are admitting for a procedure, the chart notes is important, vital signs, the referral and consultation letters, the medical reports, the correspondence with the second opinion or your other referring members, all these are important part of the medical record. And for administrative part, insurance and billing records, the release of information to the insurance company or some other agencies also part of it. And procedure, this is again very, very important. So presenting complaints, the site of surgery, I think Dr. Anil already mentioned this. I'll just go further. This is one aspect of patient care plan, which is also important from the medical legal point of view, where the judiciary expect the standard of care from us. So we need to ensure that we have a care plan and ensure that we follow this care plan. So what is the desired outcome? What are the preventive aspect? What are the curative aspect, rehabilitative aspect? So you have to ensure that this is documented in the record, and for inpatient, it has to be updated every 24 hours. And discharge summary, this is the most important document for your insurance providers and TPAs. So ensure you follow a proper format and ensure you capture all the relevant data as per the requirement. And this is very important. If patient refuse or any treatment or procedure, ensure that is documented in the record, ensure the cause or discussion with them, and also record the follow-up or telephonic information. So how do we implement? So filing and issuing to other people. So I will not go into the details, but certain points to remember, right? Description of all aspects of patient care, make all entries with date and time. And if it is medical legal cases, take more care in writing the provisional diagnosis and reason for ordering investigations. And of course, training on documentation is very, very important, and conducting an audit is very important for completion's sake. The third standard is about the confidentiality, security, and integrity of information and privileged health information. Very often patients require a lot of information from us. They want some certificate or other, the insurance wants some certificate. So all these adds to the challenge to our day-to-day practice. So what is relevant? So these are some of the standards. So this I think I've already covered. And if you are going to make corrections, so very often we have to make some corrections. So please note that this is a legal document. So if you are erasing or correcting anything, you have to authenticate it. So any error, so just cross out, make a single line cross, entries should still be legible. Both the entries should be legible. Enter the word error next to the cross out, write your initials and the date, and enter the correct information. So this is the right way of making corrections. All of us do make wrong entries. So in EMR, it is easier within a day, but in manual record, you have to ensure that you follow the right way. So how do we implement this? Maintain confidentiality of medical record. And also when you are having a department like MRD department, ensure you have a list of authorized staff to do this coding as well as auditing the case records. And data security is very, very important, particularly if you have HIV records or any such crucial entry, ensure that there is data security. And the fourth one is, where do we place the record? How do we retain them? So these are some of the laws and regulations related to medical records. So if you have a EMR, the IT Act of 2000 was recently amended after the telemedicine guidelines. Then the PNDT Act, if you are doing ultrasound based investigations, the Code of Medical Ethics, it is for all the doctors, and now NMC has updated it. The RTI Act, so some data we need to give for the Right to Know Information Act. NMC guidelines we need to follow, Telemedicine Act 2020, and each state in India, health is a state subject, so you need to follow the state legislations. So lack of storage space is a perennial problem. So you can destroy records after 10 years. Not all the records. Dr. Anil has already highlighted this. So, but if you are going to destroy it, ensure that basic information is preserved, either by scanning or microfilming or some form of information should be preserved, particularly the patient demographic details, the diagnosis, and if you have done a procedure, the details of that. And complete medical record should be retained for these special groups, the minors, mentally disabled, and when patient gives the request in writing that they want the record, particularly in ROP screening, if the parents give a request, you have to have the complete medical record for future. And who owns the document? This is oft repeated question in many of these forums. So retention policy, the time periods determined by your state. But there is a guideline given by the Director General of Health Services, and move records from active to inactive storage if they don't come to your practice for 3 years. And there are certain guidelines for transferring records, when to transfer and storage medium to be used. It has to be part of your hospital policy. Ownership, so the medical record is the doctors or healthcare providers' property, but the information in it belongs to patients. So this is where the complexity again crops up, right? This record, right? I think I'm exceeding my time. So any time limit?
That's okay, sir. We can continue.
No, sir, please continue.
Okay, maybe I'll take another 5 or 6 minutes.
Yes,
So
please.
the ownership, it's a physician property. Information record belongs to the patient. So there's a complexity here, the confidentiality clause, and how do we store and do the retention part. So the nurse's record, this is for 2 years, but if there are litigation cases, till the case is over in the highest court of law. This is very, very important for all the youngsters here. And certain registers, all our clinical registers, the government has a control over it. Particularly if you are registered under the Clinical Establishment Act, some of the registers have to be shared with the government when they need it. And the OT registers, again for 2 years. Physician index, so who all the patient we are treating, we need to maintain that index for 10 years. And certain reports with reference to medico-legal case, 5 years from inactive usage. So these are original guidelines. There are certain amendments in some of the state laws. And how do we destroy them? So we can't keep all the records because many of our clinics or hospitals are very small. So you need to identify the type of medical records to be destroyed. There has to be a procedure for destruction, and we have to notify this before destruction. So this is very important aspect from standards and medical legal point of view. And you also have to ensure there is a proper way of destroying the medical records. You can't just throw it to the person who is coming on your street collecting the old papers. And in